today we're focusing on the subject of the future of dementia care and care planning. We've got a fabulous panel with a wide range of experience, knowledge and understanding of the subject. And we're going to spend the next hour to an hour and 15 minutes talking about the issues, the opportunities and the priorities when it comes to dementia care and care planning and the future of those things. So firstly, I'm going to introduce that panel of speakers that I mentioned, and I'd like to start with Inga. And maybe Inga, if you and then the other panelists could say a little bit about yourself, the organisations you're involved with, and the work that you do in your areas of particular interest.
Yeah, thank you. Thank you for inviting me. My name is Inga. I'm a consultant clinical psychologist, and I've been working in neuropsychiatry for the past 20 years. And most of that time, I've been working with people with progressive neurological conditions like dementia. I'm also head of patient co-production and inclusion at St Andrews Healthcare, and we've been co-producing our organisational framework to ensure that we authentically implement co-production values, but in a tangible and measurable way across the whole of the charity. And then for the past 2 years, I've also been seconded as a clinical research fellow. I've been working on a research programme along with Julie, who's here today, and others with living and learnt experience of dementia. And we've been co-producing a toolkit to help care staff better co-produce care plans with people living with dementia and their partners in care, such as family or friends. So I work for St Andrews Healthcare, and I'm linked in with a number of universities as well in teaching capacities and research capacities. So that's me.
Great, thanks very much for that, Inga. And as all those watching the discussion today can see, our primary sponsor for this event is St Andrews Healthcare, who made the discussion today possible. So thank you to St Andrews Healthcare for supporting this discussion. Inga mentioned you, Julie, there and teed up your introduction. So perhaps you could introduce yourself to those people watching the discussion.
Thank you very much. My name is Julie Hayden, and I live in Halifax in West Yorkshire. My professional background is initially in nursing as a general nurse, although I did go and specialise in respiratory nursing at St Thomas's Hospital. And later on, I went on to become a social worker in older people's services. I had experience of dementia care professionally. There's been quite a lot of dementia in my family. Both my parents had dementia. But it was back 6 years ago now, at the age of 54, that I was diagnosed with young onset. And right from the start of my diagnosis, I was interested in becoming involved in research. And so my first piece of research was becoming involved in the Angela project, looking into young onset, which was funded by the Alzheimer's Society. And I then became involved with Bradford University, and my connection with them has continued through the years over various projects, and also through their Advanced Dementia Studies programme, and through other universities as well across the country. I've been involved in various main charities, the Alzheimer's Society, the DEEP Network, and also internationally via Dementia Alliance International.
That's great. Thanks very much, Julie. And we look forward to hearing more about your experience living with dementia and working with all those organisations. Victoria, could you introduce yourself, please?
Yep, hello, nice to meet you all. And so a little bit about me to start with. My name's Victoria Lyons, or Vic Lyons, as everybody tends to call me, apart from my mother. I've been an Admiral Nurse for 20 years now and been at Dementia UK for 16 years. So quite a lot of experience in working and supporting people living with dementia and their families. I've also had 5 people in my own family who've lived with dementia, so it's a topic that I obviously talk about as in a work capacity, but also occasionally in a kind of carer family member capacity. So if you don't know what we do at Dementia UK, we're a specialist nursing charity, dementia nursing charity, and we provide families with support through our Admiral Nurse method of delivering of care. So our nurses are known as Admiral Nurses. That's a direct legacy to a gentleman who had vascular dementia, and his nickname was the Admiral. So people always ask where that question comes from, where that name, sorry, comes from, but that's what Admiral Nurses do. And at Dementia UK, we support people throughout the many challenges of dementia, whether that's about helping a family member to live independently, navigating our complex healthcare system and social care system in the UK, or just actually dealing with a recent diagnosis. So it's throughout the whole pathway that somebody might be on, we provide support, and our whole method is really about empowering people to live well with this diagnosis, because with the right support, with the right care, you can live a better life with it. And yes, there's going to be challenges, but it's about making sure you've got the support when you need it to be able to cope with the things that you may need to cope with. We provide our support either through face-to-face via our Admiral Nurses working in NHS trusts and care providers across the UK, and we've got over 400 Admiral Nurses. Obviously we need lots more, but we've got 400 at the moment. And we also provide support via our helpline and our clinics, so people can contact us to get free support that way, and obviously information on our website. I was thinking about stuff that was important to me. So I lead on our digital, our dementia at work, and our work with people with learning disabilities. And these are things that I'm super passionate about, because, you know, we know that tech can make such a difference to people. We know that the way that the future is going, we obviously have to make services that are digitally enabled and ready for now, but also for the future. And in terms of dementia at work, I'm so passionate about that too, because we're all at work so much that actually making sure that workplace is dementia inclusive is vital. So they're things that I'm super passionate about as well. So, but thank you for the space to introduce myself and the charity and what we do.
No, thank you, Victoria. And last but not least, Myra, if you could introduce yourself, please.
Hi, everyone. My name is Myra. So I work at St. Andrew's Healthcare in Northampton. I am a ward manager for 4 of the 4 wards in Lauder Dementia Village. Lauder Dementia Village is a purpose-built facility looking after people living with dementia.
To you, Julie, just looking for an idea of how you feel about the status quo at the moment in terms of dementia care and care planning. What's working, what's not working, what the issues are that require address, and then maybe we'll move on once we've established where we are at the moment to talk about the future and development.
I think that the problem, a large problem at the moment is, for myself and for the people that I'm coming across, is that that it starts really for me at the beginning around diagnosis and the fact that when we're diagnosed, whether it's young onset, late onset, whatever stage, the experience tends to be that the diagnosis is delivered in an incredibly negative way, with absolutely no hope being offered of any positivity. It really is such a negative point that people are told, you've got dementia, nothing we can do about it. go away and get your end of life affairs in order, and then and at the point of getting a diagnosis, usually from a memory clinic, then no services on offer, no signposting or anything offered, and most people not actually being offered any care planning. So right from the very beginning, I think we need to get that part sorted, because unless you've got a good start, then how can you hope to have good progression and good signposting and a smoother, more positive journey through your actual care? For example, I was speaking to someone who's just diagnosed recently, within the last few weeks, and I'd already spoken to my local memory service staff and had been assured by them that they didn't give that negativity. And yet, having spoken a couple of weeks later to this lady, what I was finding from her was that she was told at the same appointment that she had dementia, that not only nothing could do about it, but this lady who's probably in her 50s, she only had 5 years left, and that was it, that she would be hearing from her local dementia hub. And so she said, I went home, I was terrified, really depressed. She said, and then when I did hear from my dementia hub, she said, practically the first words I heard from the words of the lady on the end of the phone were to say to me, have you got all your end of life affairs in order? So I think we have to start with that, giving that positivity forwards, not in kind of offering unrealistic hope to people, because we all know that dementia isn't something that can be cured and that it's a progressive condition. But it's about those messages that I think Victoria was saying about that you can live positively with your dementia, and that there is so much more that you can be both giving and receiving from life, and to be concentrating on the things that we can do rather than the things that we can't do. And let's look at care planning with regards to life, planning your life from here on in, and look at all the things that you still can do. And okay, you've got challenges in your life, but let's start with you at the center of it. Look at each of those challenges like the hub of a wheel, and how best to meet those challenges given what we know about you. And I think that's kind of the best way to go about that. But I think there's also another aspect of it, is that when you actually meet with doctors and nurses, unfortunately, there's very little, if any, training given to doctors and nurses about dementia. And that is making it completely unfair to them to throw them into practice, being completely prepared for what is identified officially now as one of the major conditions facing our country. It's certainly the biggest cause of death in this country, over and above heart disease and cancer. So, let's actually start to pull that training into the training for doctors and nurses, so that they're better prepared to deal with dementia and support people with it. And within that training has to be involving us who are living with the condition. Because having been a trained nurse and having been a social care worker and having been having family members with dementia, I thought I had a reasonable idea what dementia was about. But it's only really when you actually get it yourself that you start to realise some of the thing, the kind of the true experience of it. And so we can help the professionals with enrich their abilities and then mesh our learned and lived experience between us. And so we can hopefully make your job easier, as well as you being able to provide better for us.
Thank you for that. Sorry, Inga.
Sorry, I was just very inspired by what Julie was saying, and I just wanted to share something that a colleague of mine, Stephen Parker, who's in our Reds Recovery College, talks about, and he talks about wise expertise. And I think that's exactly what you're talking about, Julie. So you've got your professional expertise and you've got your personal expertise, and they come together for wise expertise. And it's more than either group can manage on their own. And that's the beauty of co-production.
Yeah. Can I come in as well and say something? So what I was thinking about when you spoke then, Julie, and it was amazing to hear you talk, by the way, you did such a great job there, is that, we know statistically that 1 in 2 of us is going to be affected by dementia over the course of our lifetime. And that's either because we'll have the diagnosis ourselves, we'll be the caregiver or a family member of somebody with the diagnosis, or both. So we know it's a massive condition that affects loads and loads of people, and actually we also know that many people will live with dementia without ever getting diagnosed, because we know that that's the statistic that's out there. And we also, when you were talking about training, I think there was work being done to increase awareness, to reduce some of the stigma that you're talking about, some of these misunderstandings that general public can have, but also healthcare professionals can have about what a diagnosis of dementia means. And I think there was work happening around that. So we had the National Dementia Strategy, we had Dementia Friendly Communities, we had all sorts of initiatives going on to try and tackle these things. And then, of course, COVID happened, and things kind of got worse in some ways with specialist services closing and perhaps not reopening as COVID lifts. So I think it was interesting, because when you were asked the question about what's working and what isn't, I started thinking what was working and what kind of needs to start working again, and what the future might look like. And I think some of the biggest things that are in our radar now are actually, how do we tackle things like diagnosis delays? How do we look at that kind of variability in support that people receive? Caregivers, some caregivers will get extra support, some won't get anything. They'll get very little in reality. And we know that caregivers often face really high levels of stress. And if you're doing that without significant support, that's going to have an impact on your health as well as the person you're supporting's health. So I think there's all of these things that we kind of need to kind of be having an eye on in terms of fixing in the future. And the other thing that I'm also passionate about is what we can do around prevention. So yes, we know that there's various things that you can manage certain conditions better in your lifestyle, that you can make lifestyle changes that will help reduce your risk of developing dementia in the first place. And yet we're quite passive about these things often as society. So I think if more people were aware that actually there is things that you can do that might help to maintain your health as you grow older, that can help. Of course, that's not every type of dementia, but some types are things that you can reduce. So I guess they're the things that I was thinking about while you were talking there, and actually people investing in realizing that they need to support people with this diagnosis.
Did you want to come back in there, Julie? Thank you for that, Victoria.
Yeah, I was just thinking that I think it's also important to be aware that we don't need to keep reinventing the wheel, as it were. There are some devolved nations, particularly Scotland and Wales. They are leaps and bounds ahead of England in developing dementia care pathways, and we need to be learning from them rather than trying to independently, starting from the start, from absolute start of it, and going through and developing our own way. Why don't look and take the best of other systems that are already up and running and doing well, and seeing how we can build on that and adapt it into the English system. And another thing is that the Admiral Nurse system service is absolutely fantastic. And oh God, if we could only have Admiral Nurses everywhere. But absolutely what Victoria was saying about looking at things such as technology, which can also be an extra supporter for people, particularly with either who need information and support immediately post-diagnostic, or with regards to carers as to immediate support. So that the fact that if someone doesn't have a local Admiral Nurse system in their area, then they can call the Admiral Nurse helpline and speak to someone and get advice. You know, I've got a friend who's in a very rural setting. There's nothing in her area. So I put her onto the helpline and she found them very, very useful. And I've also just recently passed the details on to that lady who's newly diagnosed, so that she's got them to hand, because I know you can set up, book a face-to-face Zoom call with you, can't you, to get some support that way.
Thanks, Julie. I mean, obviously, there's a wide range of issues there that, if addressed, could significantly improve the care that is offered, you know, across the 4 nations of the UK. I'm staggered, actually, at the lack of awareness generally when it comes to quite how far-reaching dementia is amongst the population of the UK and how much attention it gets. If we could maybe move on to looking towards the future. Inga, I know that you've been collaborating with others to develop a toolkit and a care programme. Could you talk a little bit about that and those things it's designed to address?
Yeah, absolutely. So along with Julie and others in our working groups, so I should mention Emma and Peter and Jackie and Nicola as well, who, as I say, between us, we've got living and learned experience of dementia. So we've co-created, so co-produced a toolkit. And I just wanted to quote ourselves, our co-produced explanation about co-production. So for us, co-production means working together to do something. It is about treating each other with respect and equal value. It is also about people with different experiences and ideas coming together to make things better for everyone. And this was the basis of the work that we did. This is the way that we've worked together in our programme steering group. But it's also the basis of the kind of ethos for co-production, and should be the basis for care planning. And as Julie mentioned, what I've definitely learned through speaking to lots of people with dementia as part of this programme, has been how poor care planning is, and the amount of people who've said, I don't have a care plan. And I found that really shocking. And, you know, for Myra and myself, we work at St Andrews, we work in a hospital environment. Everybody has a care plan. If there's no care plan, it gets flagged up, and, you know, it's part of our assurance process. And all care plans have to be regularly reviewed. And so I was quite shocked to learn that that often there is no plan, or if there is a plan that somebody hasn't been involved in it at all, they might not even know about it. So what we've co-produced is a toolkit. It's called the St Andrews Toolkit for Care Plan Co-Production in Dementia. It looks like this, which is very exciting for us to have it printed. And at the moment, we're trialling it on 2 of our wards in our Lyons of Dementia village. And so really the idea of the toolkit is to better help care staff to co-produce care planning. And part of the challenge is that either people don't understand what co-production is, they might assume that you can't co-produce with somebody with dementia. So people with dementia have told me that they might sit in front of a health professional with their partner, and the professional speaks to their partner, even though they're right there in front of them. And so we've got these attitudes within our society and within our health system, unfortunately, which are really entrenched. And so people think once you've got dementia, then you can't think for yourself, you can't make decisions for yourself. And of course, that's not true. What's true is that as the dementia progresses, and it sometimes are better than others for people, that they might need more support in decision making, but it doesn't mean that they can't do it. And actually, if any of us imagine having treatment for anything, and of course for dementia it's about your whole life, and somebody else making decisions about what's going to happen to you, and somebody else writing a care plan that you might not even ever see, and getting on with making decisions about your life. And when you think about that, I just couldn't imagine that. And what I've really learned through this process is that that is entirely unacceptable. And we need to get to a point where none of us would imagine care planning, so making these decisions about somebody's life without including them. So first of all, understanding that if you have dementia, that doesn't mean you can't co-produce and you can't be part of decision making. I think another challenge is that people don't realise where they are co-producing. So you might be working with somebody or caring for somebody who's in the advanced stages of dementia, and actually they're not able to have a conversation with you about their care, and they might not realise where they are, they might not know who you are. But actually, you get a really good understanding about that person by being with them, by learning from the things that they like, by knowing the things that they pick to eat, or how they respond when you're in the garden and they see roses, and by talking to partners in care, so talking to relatives and friends. And you take that information and it goes into the care planning on their behalf, because it starts to influence the discussions that are happening. So there's something about knowing you can co-produce with people with dementia. There's something about realizing that co-production looks different for different people at different times. And then there's thinking about, okay, how do we go about this? So the toolkit has 8 standard statements, practice standard statements. And so these represent how care plans should be written in full partnership with the person and those that are involved in their care. And then we have a checklist for each of these statements, and the checklist show how would I know that I'm doing it? How do I check that I'm actually meeting this standard? And so it can be used as a self-assessment tool, or you could pull all of the checklists for a group of people together and see how a care home or a ward is doing when it comes to co-production. And then the other thing we've put in there are a number of tips. And these tips have come from people who work with people with dementia, and people who care for people with dementia, and most importantly, people who are living with dementia, about how can we meet these standards. So perhaps it'd be helpful if I kind of read out what our standards are. So these are all I statements. We felt this was really important because we need to remember there's a person here. This is not a dementia patient. This is a person who is living with dementia. So number 1 is I am an equal partner in planning my care. Number 2 is I am at the heart of decision making. Number 3 is I have had a conversation about my care planning and I feel ready to start. I think that's often missing. you know, there's not even a conversation that there's such a thing as a care plan and what that might look like for that person and in that service where they are. Number 4 is that the language and approach is understandable to me. And this has got probably the most tips in there about how to best work with somebody with dementia. Number 5 is that people significant to me could be invited to be involved in planning my care where appropriate and acceptable to me. And I think this is a really interesting one. At St Andrews, we follow the triangle of care. So if we imagine the triangle and we've got the person, we've got the carers or the partners in care, and then we've got the professionals. And all of those people need to come together to support someone. But as I mentioned before, we need to make sure that this is acceptable to the person and that we don't just think, right, this person's got dementia and so we'll listen to their husband or wife or brother or whoever it is and disregard the views of the person. It needs to be that triangle. And then the last few, so number 6 is I am an expert in my own experience. My knowledge and that of my partners in care is respected and included. And that's that wise expertise that we were talking about. It's needed. It's not just a nice to have, it's a must have. And then the last 2, number 7, the steps that we're going to take together to attain my goals are clear and achievable, so that there are goals and we know how we're going to get there and we know how we're going to know that we're there. How do we measure it and how do we understand progress? And lastly, that we can review my care plan together at any time. So that is the toolkit. And as I say, at the moment, we're trialing it on 2 of our wards to see how, you know, how's that going so far. And our ambition, and I think we'll do it, won't we, Julie, is that we would like to take this on further next year, to look for a research grant and to really test this out in multiple settings with a much larger number of people and really get the evidence that this makes a difference.
That's great. Inga, Myra, are you involved in actually seeing how that works in practice at the moment on your ward?
Yes, I work with Dr. Inga in trialing the toolkit in one of my wards. So this is the toolkit that Dr. Inga was showing. So she kindly gave me a copy. We're trialing it in one of my wards, and we find it helpful. Like Dr. Inga said, the patient can be involved in the stages of care planning, because we are very quick sometimes to just say the patient is unable or unwilling to engage just because they come to us in the advanced stage of their dementia. But then, like one of our patients, one of our ladies, she's very, cognitively impaired, but by way of her behavioral cues, we've learned that she likes Christian songs, that she likes attending the church. So when she's in the church, she's settled. She seems to be listening intently to the hymns that are being sung in the church, and this is how we know that she likes attending the masses, and she was a Christian. So with that, we also involve her family, and we've asked the family what songs or what Christian hymns she was listening to, and they helped us source out CDs that we could help play.
I think we understand, you know, how it's actually been used in practice there, Myra. I think that's a great example of how you translate the theory into practice. Julia, I think you wanted to come in. One thing that strikes me listening to Inga is that not only is it just fundamental that people living with dementia are involved in their own care plans and determining how that works for them, but in the design of care planning generally at a national or regional level, people living with dementia need to have a really loud voice in designing how we invest in making sure that we look after people that are living with dementia. I don't know if you'd like to comment on that, Julie.
Yeah, absolutely. And I think the a difficulty I can foresee, as we hopefully will be introducing and rolling this out further, is that people will, although we try to make it as accessible as possible, that people will the staff will perhaps be presented with this idea of co-producing care planning, and we'll just kind of think, oh God, not another sort of piece of paperwork, another idea, another program to be working with, another kind of bit of red tape. But I think it's the way you go about things. Going back to reflecting on my social work, we would have assessment forms that when we went out to see our clients, that there will be a certain amount of information, obviously, that we needed to gather to be able to bring back into the office, put into the computer, and then use it as a basis to develop a care plan and organise services for that person. And but instead of kind of just going out and sitting down in front of a person who didn't know me from anybody else and might be quite nervous that they're older, I've just walked into their home, and me just sitting down and starting to really do a bit of a mastermind session on them by asking them question after question of what I wanted. How I went about it was I actually just invited them to, started up a conversation whereby I invited them to tell me their story. And through that natural flow of conversation, I knew the information that I needed to get from them. And I would just take from their conversation, make the occasional note, and I would maybe ask follow-up questions of them. But then it will be up to me as a professional to take that away, and then it will be up to me to make it into a format that will be the type that I will put into my computer, and to break down what had been said, what had passed between us, to go on to a care plan that would reflect what had been said, and in no way should the co-production of care planning be seen as you can only do that from the point of view of you meet a patient for the first time, and then only at that point can you all sit down, you, them, any family involved, and just all have a meeting about what's going into it. It might be that at that point that person isn't aware enough to be able to take part of that process, that point in the process. And also, as Inga has said, it's bits of information that you get from your daily interaction with that person, that you get to know things that they like, things that they prefer. As Myra was saying with her lady, that they've got to know over time about the fact that she's a religious lady. She enjoys religious music. And so that's an important issue for her. So that's something that you feed into the care planning. And that's all been co-produced because that's been her input, even though she hasn't actually sat down with you and said, actually, I'm a regular churchgoer. I really like this type of music. You've taken that from your relationship you've built up with her, gone back to her family and said, well, we've realised that she appreciates this type of music. Are there any particular tunes, hymns that she does relate to? And then you can use that within supporting that person.
I think that's a great illustration, Julie, of how necessary that direct involvement is. Victoria, can I bring you in, maybe either to address that or maybe to move on and talk also about those areas of development you would like to see both organisations and maybe even national governments focus on?
Yeah, thank you. So when you were talking, I was thinking about these amazing initiatives that are happening, and these products and tools and the toolkits and the statements you read out. I was like, hallelujah, because they're amazing statements and a great piece of work. But one of the things, Visit Dementia UK, we're a national charity, so we speak to people across the whole of the UK. And one of the things that always still shocks me to this day, actually, is how things like that sound amazing don't always get rolled out and shared, and such rich data gets gathered that can have such profound impact on someone's care delivery and experience of living with dementia. But if it stays in isolation, and that person moves to a different area or even a different postcode, sometimes it's lost. And within the NHS and within the health in the UK, we don't have one single electronic patient recording system. We don't have one record that follows the patient where they go, which means that if you go to a hospital trust that you've never been to before and it's only 5 miles down the road, they may not have access to any of the notes or the records or some of these innovations that we've been part of that could have a significant impact on the care that you receive on that visit. So I think we've still got a long way to go in terms of the digitalisation and the transformation of the NHS around how we share these things. Did you want to come back to that point?
Yeah, well, so completely agree. And I think, Julie and I and others have been part of discussions about what do we do with this toolkit, because what we found is as we've gone through our consultation process with people living with and caring for people with dementia, is that everybody wants it. They're like, when can we have it? And so we've been sort of tackling the wanting to put it out there, but also I think what's held us back has been realizing that we have to evidence that this works, and we have to not just put something out that people think, oh, that's nice and that's helpful, and they choose to pick it up or not. But we need to provide the evidence that says you need to be doing something, and here is an answer for, part of the puzzle. Here is a toolkit that you can use, and that's why we want to go on and do a bigger piece of research. I suppose also thinking about the context. So we have the CQC as the regulator for all of our services. And the CQC says we want to see co-production. We know that the Care Act says you must co-produce. The NICE guidelines say co-production, co-production, co-production. But nobody actually says, well, how are you going to do that? So I think the pressure will ramp up, that organisations, whether that's a care home, general hospital, or a mental health charity like St Andrews, will have to evidence what they're doing. And what I'm hoping is that will also help with the motivation to use these types of initiatives. And if we can provide the evidence that this is one way of doing it and show that it works, then that will help. So now I'll hand over to you, Julie.
And I'm just wondering if with the development of integrated care boards across the country, whether that might ease the rollout, hopefully, ease the rollout across health and across care. If we can convince ICBs that we have a way of working that does work, that we can evidence does produce good results, then that will hopefully make them think, okay, we'll use that in our region. And then if that can be used, because we hope that this will be, as we do roll out across a wider number of settings, that it won't just be in hospital settings, that it will be in care homes. So we need to make sure that experience over health and over social care too.
I'm just going to come in and just say one other thing. As you were saying, Victoria, about how our IT systems don't talk to each and so that continuity of care is very difficult to manage. And hopefully that's something that, well, it's going to have to be fixed, and it's a national issue. But in the meantime, I think that's where we can think about what can we do. So, you know, one of the tips in the or the checklist, sorry, in the toolkit is about, does everybody know where the care plan is and can they access it? So that we can empower people to say, I'd like a copy of my care plan, and then that can be taken to the next trust along that doesn't have your notes, so that, you know, so that people feel empowered. So although this toolkit is written for care staff, we've co-written it, we've made it as dementia friendly as we can, and really we're hoping that it will empower people so that you can go with the toolkit to your medical team or your care team, or if you're a carer, to your relatives or friends, and say, we've got a right to be involved, to or not just be involved, to co-produce in the way that works for us. There's also acknowledgement in there that not everybody wants to co-produce their care, or not everybody wants to co-produce their relatives' care. It might not be the right time. They might not ever want to do that, but they need to know that they've got that invitation. And then it's our job as healthcare professionals to create the right space to support that person to co-produce as much as they can to the level that they want to.
And I think, you know, the digital transformation will help with this as well, actually, because the more that people get involved in that, the more they are naturally co-producing, they're developing that they're involving and inputting into their care plans throughout. So now if you send an email to your GP to book an appointment, you're actually digitally recording the concerns that you've got, the things that you want. So we're shifting that landscape, aren't we, actually, to try and put people much more in control, which I think is fantastic, because actually I think as a society we're very passive about our healthcare generally, and actually the more we can do to give people it's your healthcare, you need to be in control of this, and inputting into it, and giving that message loud and clear, so that people, you know, it's kind of like the transformation that happened in the banking world, where, you know, everything went online, and we now manage our money ourselves a lot more than we used to rely on our bank tellers and bank managers. Kind of need to do the similar thing with our healthcare, so that we're not sitting there passively just allowing other people to decide what we need when we need it, but driving some of that ourselves. And I think in the NHS of course is patchy, we know that, but it's patchy because it's not one great big thing, is it? It's a series of different boards and bodies running a system that's all gets under that umbrella term of the NHS. So it is difficult. I'd like to think we'll get to a point at some point where there is, the shareable electronic records and things, because that will make, we know, the quality of care so much better. But I think there's some way to go on that yet. I can't remember the first time I had a roundtable discussion about that, but we'll get there eventually, I'm sure. We have to, right? And I guess I was thinking about some of the things that we're doing at Dementia UK around this, and then some of the tech stuff for the future, because I think this is quite interesting. So at Dementia UK, we've been looking at, we obviously start by looking at our website, looking at the resources that are there, the things that we put out for people to share on social media, all about raising awareness, raising support, about making people feel empowered to take charge of their healthcare and their diagnosis. We're looking at things like, as you very, very kindly mentioned, virtual appointments, so appointments that someone can book, and a nurse will zoom in or Teams into their home and have that conversation with them. And we're also looking at all sorts of things like AI technology and thinking about how can that support us and help us. I'm quite keen on things like AI chatbots that run off select URLs, so you can trust the content and it doesn't have all sorts of hallucinations all over the place. But so we're looking at these kinds of things to think, actually, how can we empower people even more to take control? And I think that's some of the future that we're looking at, and taking dementia care into people's living rooms. So you don't go to a clinic somewhere. You might have to for some things, but where possible, your care to be delivered as close to home as possible, because that's what we all want. We, you know, ideally you'd want to have support and care in your own home. And then I'm always thinking about how technology can help us, because thinking forward to the future. And I was talking to someone the other day who was talking about the use of Alexa and these reminder apps that they use to enable them to stay independent in their own home with using these technologies. You know, so you can have medication reminders, boxes that tell you when your pills need to go to be taken. You can even find socks that tell you if you're likely to fall, and you know, all sorts of things out there. We know about GPS trackers, location devices, how they can help. Again, Alexa are other tools, obviously, but we're thinking about communication, social engagement, isolation, all of these things that we know people might experience throughout the course of their lifetime. And things like video calls can really help with that. If you're, you know, living far away, I'm 200 miles away from my family, but I can FaceTime them, I can video call them and have that communication with them. Who knows, maybe even in the future we'll use VR handsets to headsets to communicate with people and have that really immersive experience. Then the other side, of course, we know that there's technology that can help to safeguard people, you know, can keep people safe in their homes, and technology to stop baths overflowing or kettles and pans boiling dry. And, you know, and when people go outside of their door, caregivers receive an alert to say someone's gone out. Tracking devices are, where are they? Are they home? Where might they be? So there's all of this stuff going on, but I think what we've, and that's just the tip of it really, I could list many more, but I'm sure you would know them. It's about looking at what's going on in the tech world, what's going on outside of the dementia world, and thinking how can we enhance some of this and bring it in to our world, you know, and use that in a productive and meaningful way. So I think that's kind of where I look to the future, and I think it's exciting. I think, you know, we can revolutionise the whole pathway for people, but it's going to take some doing and some investment. But I think you wanted to come in there.
Yeah, it would just completely agree with you, and just makes me think about a couple of our projects here at St Andrews. So we did a feasibility study a few years ago about virtual reality. Use of virtual reality with people with dementia, even those who, you know, don't have capacity to kind of consent and to make those decisions. And what we found was that it was feasible, and that people really enjoyed it. And it's been really interesting. That paper's been referenced a lot internationally, because I think it's really excited people to be able to think about the possibilities of what they could do. But another project comes to mind. So we've got a Memjo project, which is a tablet-based project, and we're just about to go into phase 2. And this was some product development that we've done with the people in our care at St Andrews. So this has been people living with dementia and also people living with Huntington's disease. And the tablet is about trying to utilise all of that technology that we use in our everyday life, but can become inaccessible for people. So, you know, it might be that an older person will have drier skin, and so touch screens can be problematic, for example, or how to navigate through all of the different pages and options and everything in order to get to what you need. So the Memjo tablet is about reminiscence, it's about cognitive stimulation. We want to bring in life story work, but we also want to be able to use it as a platform for social interaction. So like you were saying, you know, we use video calling, but actually we've got so many different platforms by which we can contact people, and it becomes quite confusing, doesn't it? I think we all know that we think, I have a message somewhere, and we can't remember where that message was. We know who it was with, but we don't know how we touch base. And so with the Memjo tablet, we're looking at how we can have an interface which is dementia friendly, or cognitive impairment friendly, so that you would be able to have contact with your relatives, with your friends, the outside world, and it doesn't matter how they contact you, it would all come through an interface that made sense. So I think technology is really exciting. On its own, it doesn't fix our problems, but it can absolutely help us to understand each other better, to be in contact better, to think about safety. I mean, one of the other things, again, sort of just thinking about the Memjo, was using computer learning, so that where it can be quite it can be quite tricky in care planning when you might not be able to ask the person what they like. And so we're looking at, as Myra was talking about, we're looking at the sort of behaviours that we see. How does somebody react to the environment? And we look back through notes and we talk to everybody who has current contact with that person and has in the past, to try and pull all of this together. What we've realised with Memjo is that we can use computer learning to see, what does somebody like? Where do they spend more time looking? What buttons do they press more? And so we're looking at how that can then actually provide a report, so that the care team or the relatives can have some extra clues about what the interests are of an individual. So technology, I think, can do a lot. It can make what we do as humans easier, but actually it can provide information like socks that are able to notice the way that somebody's feet are planted on the floor and how they're walking around, that actually as humans we wouldn't be able to elicit on our own. So yeah, I think it's going to be really interesting to see how technology, where that takes us in the future, and we're going to have to be innovative and thoughtful about it.
And I think the thing to say as well, as I know I said it earlier as well, but it's looking at what's going on elsewhere. So I was watching I'm assuming it's okay to say, the Apple launch last night, where they're launching the new things that they're bringing forward. And one of the things they were talking about is a download for your phone, which you can will display your picture when you ring somebody. And instantly I'm watching this and my brain's thinking, actually, that would be a fantastic tool for my mum to be able to, my mother-in-law, sorry, to be able to when we call her, for a picture to appear, so she knows it's us who's calling. And so my brain's constantly looking at these things and going, oh, that could be really useful for somebody living with dementia. But I guess the other side of it is these things are so beautifully built, and they're nice to use, and I think we need to make sure that the products we're building and developing and designing are ones that people are going to want to use, because otherwise you're not going to get that uptake. And if you're nowadays we've all had mobile phones for quite a long time, and we expect a certain level of quality from that device. So I think it's about making sure that people aren't presented with something that looks a bit ugly or a bit like a child's. It's got to be a slick, nice product that you want to engage with and use. And that's the challenge when you're looking at these things, because often finances are a challenge as well. So how do you ever compete with some of these large companies? But if we work in collaboration with them, perhaps that's some of the exciting ways forward, is to say, this is a real world problem where we know that 1 in 2 of us are going to develop dementia or be affected by dementia, sorry. So how can we work with people, whoever they might be in that world, to say, actually, can you help? Can we collaborate together to find some solutions?
It's clear that technology does have the ability to completely transform, the future of dementia care. I think we may well come back and have a separate roundtable discussion about technology and the impact it has. I want to try and bring the discussion towards a sort of conclusion now. But Julie, I think maybe you wanted to say something. So before I do that and ask for final comments, would you like to come in?
I was just going to say, technology is far where we can fit it into people's lives, and there's such a wealth and an ever-growing wealth of tech support that we can turn to there. I think that, and I know that you aren't meaning it that way, but I think we have to be very conscious of the fact that technology is only ever going to be a tool. It can never be a replacement for people support and people contact, because we are people. And also I think that the care professionals and society in general tends to be sort of quite ageist, in that they assume if someone's over a certain age, there's no point in introducing them to technology because they're not going to be able to cope with it. Well, actually, if you choose the appropriate level of tech and someone actually is able to sit down and take them through it, people can come to terms with and learn how to use certain types of technology. But certainly, I think an important thing is that after diagnosis, something that I'd like to see is very early intervention with support, because at the moment, with both health and with social care, you get your diagnosis and then pretty soon afterwards you're just dropped, and it's like you try to approach anyone for help and it's like, I'm sorry, come away when you're worse, when you're further down your journey. And I think if we can jump in and be offering support earlier on, that enables people to stay stronger for longer, and so be able to be living in their own homes and to be living independently and to be connecting people in with things like peer support groups, where we sit around and we actually give people the very tips that say, well, not only are we understanding because we've been through the same issues, but also we, having been through those challenges, that if you're having difficulty with something, you know what, we found that when we came across that we found this really helpful to us with regards to, as opposed to approaching this particular aspect of daily living in a certain way. If you actually plan it in a different way, that you can still achieve it. And so that, and if that tip doesn't work for one person, somebody else in the group will say, well, actually, I found that this way helped for me, that I could still manage that particular task by working in this way, or just with a little bit of help or a little bit of rearrangement around my home, that became still a possibility for me. So I think it's keeping that that wide range of possibilities, but also it's making sure that we have that early intervention, which at the moment we don't have.
Great, thanks, Julie. You may already have anticipated my sort of summary, and possibly not, but I'll come to you firstly, Julie. I'd just like to quickly go around the panel as we bring the discussion to a close and ask everybody if there was sort of one thing that you'd regard as the biggest priority in terms of moving dementia care and care planning forward. You know, I assume that listening to this are not just lots of your colleagues and peers, but maybe senior politicians, policymakers. You know, what would each of you on the panel, starting with you, Julie, say to them was the overwhelming priority, if there is one, in terms of where we put our focus now? If I can come to you firstly, Julie. Sorry to put you on the spot.
That's okay. I mean, I think they have to speak to us for a start. I mean, trying to pick a time when politicians ever speak to us. I think politicians tend to assume that if you've got a dementia diagnosis, then you don't have the capability to have any reasoned discussion, because, I don't think they even realise that right up to the point that we lose our cognition completely, we still have the right to vote. So we are still your voters. Come and talk to us about care and about planning approach and so on. But making them realise that we are still a useful member of society. We still retain the skills that we've built up and developed during life. And so they can still be utilised. And by making sure that we have a a possibility to still use that, particularly those, as you go on, you develop more age-related conditions, but particularly in relation to young onset, that you might have had your working career cut short because of your dementia, but you still got skills. And what we need is we need to still feel useful. It's a large part of my life, what's kind of given me the interest in carrying on is that I've wanted to feel useful. That's why I wanted to be a nurse. That's why I wanted to be a social worker. And so at least kind of having got involved in research and having got involved in activism, that's given me effectively a third career. It's given me a purpose to carry on. And that work has then fed back into me, and it's kept my cognition going, and it's been very good, very effective in being a way of being very therapeutic to me. So in that way, I can still be of use to society, and the work becomes useful to me.
Brilliant, Julie. I think as people, we all need to feel useful and have a sense of purpose, don't we? Victoria, the big priority for you in terms of moving dementia care forward?
I think for me, I'd obviously have to start off by saying I would like to have more Admiral nurses working across the UK. I think having our Admiral Nurse dementia specialist nurses embedded and able to support people and work with people would massively transform things, and having access to that specialist support for people when they need it. And actually, there's a role there in terms of providing that training and support to healthcare providers as well, to our healthcare professionals who we work with. So that's a key strategy objective for me, is to kind of roll out and to work with different health bodies and people to set up more services. But I guess if I think globally of what I'd like politicians to think about it, I'm going to take us right back to what we started talking about actually, which was about that reduction of stigma, raising awareness, making things dementia inclusive, so that people wherever they are can live as well as possible, because there's no cure for dementia. So it's actually it's the things that you need in life to enable you to live an independent life. Obviously, technology is going to play a part of that, but that needs to be tailored, and it needs to be individual to that person and their care plan and their situation. So I guess that would be my overall hope. And I'm going to take us back again to co-production, because I lead on our work with learning disabilities, and we often talk about nothing about us without us in that setting. And I think that's something we need to remember in dementia care as well, and listen to the people working with people with dementia, the family caregivers, and of course the people living with dementia, so that things are being developed and put in place that are the right things, rather than something that somebody else thinks is the right thing, or the right strategy or set of objectives to drive towards.
That's great. Thanks, Victoria. Myra, is there one big thing, or it might not be a big thing, a significant thing that you think would help improve dementia care? You're on mute, Myra.
Again, okay. I think one of the biggest challenges in the nursing side is the resources that we have. As everybody knows, we are faced with staffing difficulties. And I think one way of improving dementia care, and of course, improving the quality of life of the people that we work with, is to give us the resources that we need on the ground. So if we have more people on the ground, then we will have this opportunity and these resources to promote quality of life. I'm really passionate about promoting quality of life for patients living with dementia. When they come to us, they're very ill, and so there's very little we can do. But in terms of promoting quality of life or engaging them in meaningful activities. But we can try, like for example, the lady that I was talking to you about. So this lady, basically, she enjoys going to church and listening to Christian music. So if we have the right resources on the ground, then we can support this lady, do the activities that she's passionate about. I think this is one of the things that sometimes is overlooked. It's refreshing to listen to Julie, to know the other side of the story, because, like for example, when we admit patients, they aren't able to tell us what they want, how they would like things to be, and if we have a care plan that has been co-produced by this patient when they were still able to voice out their wishes and preferences, it would help us a great deal to look after this patient. Because most of the time we will be talking to their carers, because we would say, oh, they're not able to engage in a meaningful conversation. But like Dr. Inga said, they are able to contribute at any stage of their condition, whether it be behavioral cues or physical cues. They will be able to co-produce care plans in any stage of their condition. But like I said, if their care plan were co-produced at the time when they're still able to express themselves, then that would be a great deal of help for us nurses to look after our patients. Because when they come to us, they often require complex care and a lot of stabilization. So it might be a different scenario as to what Julie is saying, but if we all come together and co-produce a care plan that is reflective of the need or the person that we are looking after, then that would be a great help for the nursing team.
Great. Thanks very much for that, Myra. So Inga, you get the final word. Big priority in terms of improving dementia care.
Well, I get the benefit that so many wonderful things have already been covered, and so I'd go back to really what we talked about right at the beginning, and you used the word hope, Julie, and actually at St Andrews our purpose is hope. We've sort of boiled it down, taken all the words out and thought, what is it? And it is hope. And so what I want is a cultural revolution. I want co-production to not even be a thing, because it's just what we live by every single day, that we would never imagine making a plan about somebody without working with them in whatever way they're able to at that time, or whatever way they feel, whatever they can do at that time, and that can change. So I think that's what it's about. It's about changing culture. And, nothing's free, but it's the cheapest thing we can do, because that's about us reflecting. That's about conversations. It's about bringing it through in training, but also bringing it through in policy. We need to be held to account. It needs to be unacceptable that care is not co-produced. And care planning is something tangible, something we can see and read. And so we can look for the evidence, and we can demand the evidence that shows that it's been co-produced. So there we go. Cultural change would be my one big thing.
Thank you very much, Inga. I can't think of a better note in which to finish than that rallying cry of cultural revolution. I love that. Can I just thank all of our panelists? I think it's been an inspiring, passionate, and incredibly well-informed discussion. For all those that are watching this NR Times Roundtable sponsored by St Andrews Healthcare, please share it as widely as possible. This discussion really does deserve to be shared as widely as possible. I think it's been a fabulous discussion. I'm sure we'll come back and follow up on some of those threads. I think the technology thread with the qualifications that Julie mentioned there deserves a lot more discussion and airtime, and it'd be great if we could go back and look at that again. So to Dr. Inga Stewart, Myra, Victoria and Julie, thank you ever so much. It's been a pleasure to participate and to listen to you talk and discuss some of these crucially important issues. And for all those that are watching, final reminder, please share this discussion. It really does deserve it. Thank you.
Thank you.
Thank you, Alastair.
Thank you.